Hello from sunny Queensland. My name is Lieutenant Nick Hill, and this is Team Resuscitation, the Role 1 or the Med Det, and you. Doing this to be able to consolidate some knowledge, get some conversation started, and get talking amongst the unit to be able to consolidate knowledge that we already have. So, NATO Logistics Handbook. You can find this, it's an open source document. And Chapter 16 in the NATO Logistics Handbook talks about medical support. Now you can read what's on the screen, but to paraphrase it, it's an integral part of a small unit's existence and it will conduct life-saving interventions and measures, first aid, ambulatory care, so being that sick parade, and then also triage in a mass casualty environment. Prevention of diseases happens here, non-battle injuries, and operational stress, including psychological injury. So it is a one-stop shop. So let's have a look at some demonstrations of Role 1s and what they may look like in the battle space. So on the left-hand image, we have an ambulatory care or sick parade tent. It's set up with some harder beds like we would have in sick parade in a garrison facility in New Zealand. It's well ventilated. It has a semi-hard standing flooring to keep infection control limited or reduced, and it looks pretty bougie, to be honest with you. It also has white light. Whereas if we look at the next image to the top right, we can see that is a British Role 1. It is in a smaller ADT with the Red Cross labelled on it. It has a camping chair at the front for the triage officer, who may be a sergeant or a lieutenant, maybe even a corporal. It has two quad bikes which are used to retrieve and deliver patients to an HLZ or from point of injury back to the Role 1. You can see it has a marshalling area with white tape to be able to designate flow and processing to get to the main door. And you can see that the tent itself is quite a small space. Bottom right is a bit more hard standing, and this is the infamous FOB Price Medical Centre, which was a Role 1 in Afghanistan. You can see that there are connexes set up and a seat for ambulatory or sick parade patients to be able to sit down on. You can see they've set up fire extinguishers in case there's a fire, and it looks less so for the acute traumatic patient, most likely because they're going directly to a Role 2. But this Role 1 has an ambulatory care focus, and FOB Price was infamous for its ability to be able to take the load off the Role 2 with ambulatory care in Afghanistan. So right here we have some good examples of some more Gucci high-speed Role 1s. Now this is taken from an Instagram page called @FordSurge, Surge spelled S-U-R-G-E. There are some very good examples of light surgical models in there, but these are Role 1s that probably have a little bit more bolted onto them, and you might call them a Role 1 enhanced or advanced or plus, but yeah, there you go. So on the left-hand image, you can see a mass cas roll bag, which is fitted with some nursing care equipment, including maybe a 24-hour urine collection device. Next to it is obviously a standing lamp, so these guys have power to access. Then there is a mass cas roll bag with drugs in it, a fluid infuser bag. You can see an M9 aid bag. Next to that, to the right, in front of the sandbags is maybe a fluid warmer and a fluid pole. Then some airway equipment in a bag to the right of that. You can see the warming blanket already laid out on the NATO stretcher. There's a rubbish bag at the end of the bed, a clipboard, a whole lot of adjunctive gears, probably including underwater seal drains for chest drains, fluid warmers, binding equipment, cleaning equipment. There's obviously shears attached to it. So there's a fair bit of stuff going on there. A little bit more bougie and high speed with power especially, but a really good example of making the best of the space and setting up in preparation for your patient's arrival. Top right is Craig's Corner. Craig's Corner is from H. Kaya, and this was set up in the corner of a aid space. And you can definitely see the surgical equipment in the foreground of this image. The NATO stretcher is set up already with warming devices and blankets, and is on a North American Rescue NATO trolley, which our roll 2 have. You can see there's a series of aid bags opened up and maybe some fluid warmers or bear huggers in the back left underneath the aid bag. So quite an effective setup there. The bottom one, I believe, is from Syria. And this NATO stretcher has a biohaz bag at the foot of the bed there, the red thing. It also has some surgical fields established already and multiple MassCas roll bags set up on the walls. You can see at the head of the bed, opposite the red bag, there's a series of what appear to be underwater seal drains ready to go, and also maybe some monitoring equipment and some airway adjuncts to the right-hand side of that bottom right image. So the FM-02, or the Army Health System Doctrine from the United States, I chose this instead of the UK or Australian one because it has less ambiguity in the black and white, and it basically tells us exactly what the rule book is for what a roll 1 should be. So the address is down the bottom. In the show notes, you'll be able to access the HTTP from the hyperlink in the PDF, and then follow it in and see exactly what is expected of a roll 1, roll 2, roll 3, roll 4, the logistics systems that enable them to happen, and then the transport system being by air or ground, and what their expectations are of timelines, positioning, capabilities, logistical reinforcement, etc. So that's the FM4-02. Okay, so a study from Johnson et al. There's some well-known names in this. This basically is an analysis across the Roll 1 guidelines, including the Prolonged Field Care Guidelines and TCCC guidelines, or Tactical Combat Casualty Care guidelines. The hyperlink is in the bottom of this page here to be able to go to be able to have a look at this study. At the end of this presentation, in the show notes, there is basically the cross-examination of TCCC, Prolonged Field Care, and then the analysis of what each facility, roll 1, 2, 3, but then also point of care being the medic on the ground are expected to do, as well as combat first aider or DFANS first aider, for example. So they're at the end of this presentation. I won't talk to them because they're pretty self-explanatory. They're also very dense, so it's going to take up a lot of time, but you can read them for yourselves if you're interested. Okay, so let's talk about this slide. We'll get into heaps more detail down the line, but basically we're going to work from the outside in, top down. So we're looking over the top of a bed or a stretcher at the moment. The red dotted line indicates a clinical only space. So if you're in the resuscitation team or the roll 1, or if you're in a roll 2 as well, this is clinicians and patient only. The top down is the blue circle indicates an airway interventionalist. This can be a doctor, medic, or a nurse that are familiar and confident in airway interventions. The green rectangle indicates the patient's bed, and the black triangle indicates where the head should be. The red circle is the wet or the access person. This is generally speaking a nurse or a medic, but it can also be a doctor if the procedure is too advanced for those scopes. They have a yellow circle around the outside of them because their role is interchangeable with dry. Dry could also be a procedural nurse or medic, but it can also be a doctor if the advanced scope then encroaches in what they're doing. And this role, as I said before, is interchangeable with wet. The specifics of these roles I'll go through shortly. The grey circle down the bottom is the scribe, and this can be either a senior NCO or senior non-commissioned officer medic or a nurse. And it has a blue halo because that scribe can then be interchangeable with airway. At the base of the bed you have a black circle, and that is your team leader or TL. And this, generally speaking, will be a very senior nurse or a doctor. This team leader can be interchangeable in any of the other areas, but generally speaking can be an assistant or a secondary to the airway, or as the airway doctor, or can also do a intervention with wet or dry. Cool. Now let's say we start losing team members. you may have a composition looking like this, and if that's the case, you can see that airway is now gone and the team leader has become your airway controller. If this is the case, it can have a bias or a focus only on the airway, and you'll see this with a lot of well-trained anaesthetists who are used to working alone, controlling an airway and having an airway assistant in the form of a nurse or an anaesthetic technician if you're in Australia and New Zealand. That's cool, but if they're controlling the airway, it's that they've done an intervention, and if they've finished that intervention, generally speaking, it would be preferable that that person can step away from the airway, come to the end of the bed, and continue to have a non-focus on an intervention and then see from a glance backwards, because it's hard to keep neutral in a resuscitation environment where there's stress, a high cognitive load, by being focused solely on one area or environment. So that airway interventionist then needs to take a step away and either ask someone to control or manage the airway, hold the tube, being a endotracheal tube or a crike, etc., and then focus from a glance back. Next iteration could be a two-person team, and they would work interchangeably from side to side and work together with a shared mental focus. And you might see teams turning down their volume or size as acuity and patient load comes in. So the more patients that a team gets, they may have to take people away to interchange into these roles. And then again, you can see this one here, definitely toning it down. The one-person team, this is in mass cal or mass casualty environments where the patient has already been triaged, they've been brought into the bed space, and this person is going hell for leather by themselves. If this is happening, this is an isolation, this is an austerity, this is the worst case scenario. So yeah. Okay, so we have identified who people are and where they are. We'll go from the outside in, top down, and I'll also go left to right as well, just to give some structure about what's where and what they are as we see it on the screen. So we can see those green boxes on the left-hand side of the screen here. That is your C, A, B, C, D boxes, and that could be your catastrophic hemorrhage control, so tourniquets, hemostatic gauzes in the C, along with IVs, but any of those adjuncts to that, which might be TXA, so transischemic acid, or blood in that C box as well. And so that could be a Pelican case, that could be a space case, that could be a multitude of things. A is your second line airway adjuncts, so all the equipment you need to replace after you've intervened, and we'll talk about why in a second. But then B could be your chest drains, decompression needles, your finger thoracotomy kits, your Heimlich drains, your all your breathing intervention adjunct stuff. It could also include breathing tubes for ventilators and bag valve masks, etc., etc. D could be a combination of drugs, medications, pelvic splints, splinting equipment, and this again is your second or third line. So when you've totally expended a caseload's worth of equipment, this is these four green boxes to the left-hand side, all your second and third line to restock any of your equipment. So we see the red dotted line for the clinicians and patient only. Our red box or trolley could be our IV access, our IOs, our drugs, our fluid warmer. The grey box at the head of the bed next to the airway is your airway adjuncts, being a Goodell or an OPA. It could be a nasopharyngeal airway or an NPA. It could be a suction device, including our Liddell suction devices we have in service in the NZDF. To the left of the airway person, on the right of the screen, you can see, if you have the luxury of having it, a monitor. For the NZDF, this is the Zoll MD, which has a defibrillator function on it as well as monitoring. But if you don't, it could be monitoring equipment such as a manual sphyganometer, maybe a SATS probe, a EMA, so an end-tidal CO2 monitor, etc., etc. Next to that, if you have the luxury, it could be a ventilator. So our in-service ventilator in New Zealand is the Hamilton T1. If you didn't have the Hamilton T1, then it could be a bag valve mask. And you could already have that end-tidal CO2 pre-fitted to it, so an EMA or another point-of-care device. Moving down, you can see the tray or trolley for your next person, which is shears. It could be a pelvic binder, that chest drain or chest darts, splinting devices, including a Kendrick's traction device or a KTD, and it potentially could have point-of-care ultrasound. And with the advances in point-of-care ultrasound beyond that of, say, the Fujifilm Sonosite, we also now have some more advanced devices from Philips and the like that can be used on cell phones and ATACs for us to be able to do diagnostic ultrasound. There are advances in that field, but I would strongly suggest that Roll 1 should start investing and looking at those point-of-care ultrasound devices that are very, very effective. And I have quite a deep experience with the Butterfly IQ ultrasound device, and I think it is a perfect ultrasound for its cost, but also its size. We can see in front of the TL, we can see that bio waste bag, and in New Zealand we use yellow ones, but our American and Canadian colleagues sometimes use red ones, and that could be hung off the end of our NATO stretcher, but it also could be attached to maybe a piece of wood or have its own stand for us to be able to put dirty or soiled clothing, any of our mucky gauze swabs, combines, any of our wet or biohazardous materials go into that one, but no sharps. Sharps would obviously be with either our wet or our dry, depending on who they are. So I really want to iron out some points from the team. I want to talk about this before we go into flow processes and individual skill sets. The team is probably the biggest part of what a Roll 1, Roll 2, and Roll 3 are about. It's not about the individuals, it's about working together to resuscitate your patient. And I'm really strong on this. And this is especially the soft skills, okay? So that's about how we communicate and interact with each other. Something that our British colleagues do incredibly well is time rigor or time stamps. They lock down, and they have learnt from Iraq and Afghanistan, solid timelines within the team resuscitative process for handovers such as the IMIST, for assessment and initial trauma survey. So that could be your doctor's march or doctor's MAR, so MAR only, or CABC, CABCDE. So those are very strongly rigored by them, and they are extremely professional in their team resuscitation pathways. They keep it to basically a timeline, and if they blow through the timeline, they move straight on to the next thing. As part of team interaction, effective closed loop communication is really, really important. And I talk about this because if we do not close the loop within a team environment, things can be missed. And so what I mean is team leader says to our drugs or our wet person, I want you to give 1 gram TXA bolus now. And the C person or the wet person will come back and say, 1346, 1 gram TXA given through the right antecubical fossa or right ACF. Now that's extremely detailed, but you get the idea of closing the loop and telling team leader, I have done what you've asked me, we've continued on. As part of that team environment, cool, calm, quiet, and effective resuscitation skills are really important. So the projection of sound, unnecessary noise or communication, stress is all needs to be toned down, and that cool and calm, collective, and effective communication is important. So we don't shout and yell over the top of each other, because that can then start manifesting into physical things such as running around or tripping over equipment, etc., etc. So keeping cool and calm is really important in this process. Effective clinical resource management and CRM is something that's evolved out of the aviation industry and crew resource management. This is about using checklists for, say, our rigor of how we resuscitate. So CABC is a good example of that. So catastrophic hemorrhage, airway, breathing, circulation. And it's a step-by-step process that's time-stamped and kept to a very limited process. Okay, so there's not much fluff in it. I want to talk about horizontal rank environments. Now, for those of you who are in this environment and have come from infantry, armor, sometimes aviation and artillery, there is a hierarchy, there is a rank structure for a good reason. But a horizontal rank environment in medical and resuscitation is about the team leader is the team leader regardless of rank, regardless of their skill set. They've been appointed there by either the team or the clinicians within the chain of command to lead that resuscitation team. And therefore the rigor goes through the team leader. The airway person does not take prioritization. They delegate their control to the team leader. So it's horizontal, everyone has commonality, and we talk to each other through roles or first name basis and not rank. And that's really important. And I reinforce that because if we start to involve rank, the power gradient and the structure changes, and we give people, say for example, an anaesthetist who's a major or a lieutenant colonel in the airway, the power over, say, a captain nursing officer who is our team leader. And if they've been delegated command and control of that team, they are the team leader. So therefore we take the lead off them. The next point is where we rehearse in each other's roles, and rehearsing team roles is really important, but understanding the next person's job within the team. So understanding how to do a finger thoracotomy or decompress the chest using a chest dart should be the lowest iteration, for example, of what the team can do. Everyone should be able to put on a tourniquet. Everyone should be able to do a jaw thrust on a patient, or put in a Goodell, or put in an MPA, or use an intraosseous or IO device on the patient and know exactly where to place it, exactly where the equipment lives, and where our second and third line equipment and those space boxes are. In saying that, there needs to have a level of subject matter expertise, and those experts could be our advanced airway interventionalists who know how to do trachees or advanced cricothyrotomies under stress, but also how to ventilate correctly, and are the masters and the super users on, say, a ventilator or an IO device or the suction device, or how to do medical interventions or what medications are appropriate for what. But also how they teach and share is a really important part about that. Yes, they might be SMEs, but they should be able to teach and train others. And this is the difference between being a good clinician and a great teacher, is that not all good clinicians can teach. The last point on the team environment is common word pictures, phrases, signals, or procedures. And this is about using common language. Now, if you work in Five Eyes, so the UK, US, Canada, Australia, and New Zealand, some slang and terminology is different. And so if you come to a role one in the Five Eyes community, for example, you have to understand what exactly they're asking for. And that common word picture of, say, I want albuterol is actually the drug salbutamol. It's just a different name, right? And so that's a good example of a medication that's a little bit different. But then slang and terminology is another part of this, and ourselves and the Australians have a terrible reputation for slang getting in the way of effective communication. We're not perfect. So, looking at a common word picture or a phrase is really important. And especially when you work in a NATO environment with so many cultures, so many different phrases or slang and colloquialisms, we need to come together and have a common word picture. If we look at the lowest iteration of what that means, in our environment, all New Zealanders, all in a team setting, then we need to know exactly what the phrase or term means. And that comes back to closed loop communication. So what you can see on the screen in front of you is about flows and processes. And this is really, really, really important. As I say, the British are incredibly good at this, and they take structure and organization out of chaos. So looking at it, C2 is command and control. So that's your med-det platoon commander, platoon sergeant, staff sergeant, and extremis, maybe even a squadron sergeant major. Gives the advance warning that a patient is coming and tell you what the mechanism and the injury might be. So that then means that the team prepares, okay? And then the team shares together exactly what they're going to do. So the TL or the team leader says, team, we're about to get this patient, this is the mechanism and the injury. What I want to happen is we're going to have eye mist or a mist from our paramedic delivering them. We will have a handover. Then I want them to be triaged quickly on the bed and have them identified thereafter. Airway, I want you to assess the airway and do C-spine assessment shortly thereafter. And then we will continue thereon and take a pause point at the end of our exposure and environmental control. And so that preparation sets a good mental gradient for the team. All team members are ready when that TL is there. So we draw the team in from, say, the smoko area, the stand easy, or the Joe area if you're in the Air Force. They come together, they communicate that, and everyone is there to start, okay? So that then sets a gradient of communication for everyone in the team that they're ready and set. Next part after prepare is the IMIS, so introduction, mechanism, injury, signs and symptoms, and treatment. This also includes security, and this is, if you have them, wanding your patient to check for any metal or explosive devices, bullets, rounds, whatever it might be on the patient. Now, this is a lesson learnt from Afghanistan for New Zealand. A deceased comrade of ours returned to a mortuary in Christchurch and had his clothing cut open and a grenade was found on his body. And so this is the importance of why we decontaminate and remove devices and explosives, etc., when they're wandered on triage. We also make sure that we identify them correctly, and this is either a unique identifier for the patient, be that a 3-letter, 3-number combination, so ABC 123 for our first patient of the day, and all notes, be observation charts, ECGs, then have ABC 123 for that patient. And that's the importance of processing and identifying our patient as they're sent down the retrieval line. The British use ZAP numbers or unique identifiers that are on Velcro patches on their sleeves. They use those well in Afghanistan, and those ZAP numbers were used on radio systems and IT portals so that the patient's identity was not revealed to others unless they had a ZAP number sheet in front of them. The other stuff's implied, and this is about airway and C-spine could be hemorrhage control, and then airway would then come after it. But then we have breathing, circulation, disability, and I've put DFG, which is don't forget the glucose, exposure and environmental control. So we need to expose the abdomen, the limbs, the legs, the head, etc., remove any equipment and bag it, and that would be the scribe's responsibility, but I'll talk about that in detail in a second. The biggest part of this is that if you do CABC or ABCDE or Doctor's March or MAR, then there has to be a pause point, because this is known as the initial assessment. We then take, at the end of the initial assessment, a pause point. And this then helps our team leader decide, okay, from here, we are going to do blah. We are going with blah, so on and so forth. So continuing the flows and processes, and this one can be interchangeable, and standard operating procedures, or SOPs, can be molded to whatever the experience and the expectations of the organization or team are. But they need to be locked in well in advance before you touch your first patient. So this then means that Team leaders, doctors, nurses, senior medics are the ones who decide what they are using as their rigor for their interventions and processes. Be that CABC, which is very Anglo-centric. The Brits use that a lot. Americans, Canadians, Australians, New Zealanders probably use more than most MARCH or MAR, so massive bleeding airway respiration. Whatever it might be, as I say, rehearsals and then locking in exactly what that resuscitative process is. Most of this is self-explanatory, but an important part of this is posterior surface checks. So that's also including thorough top to toe, including examination and observation of the axilla, so the armpit, as well as, say, the rectal area, the testes, the back, and then around the pelvis, because any of those injuries that are missed, although minor, from lessons learned, can be life-threatening, especially with things in the axilla. A nurse within the unit will be able to reinforce this, but there was an injury pattern that was missed on a patient. They obtunded, and it turned out that they actually had a sucking chest wound in the axilla that had been missed at primary point of care through to the Role 1 ongoing to Role 2. So that's the importance of doing those thorough top-to-toe assessments as well as posterior surface checks. Re-evaluation of interventions is also a very important part of this, and that's a pause point. And so the team leader says, team, we're going to pause here. Everyone listen to me. Okay, airway, continue to ventilate the patient, please. Is that tourniquet on the right arm effective? Okay, it is not. Team, I would like a second tourniquet applied. Wet, can you please apply a second tourniquet to that right arm? The wet would then say a second tourniquet applied at 14:31 hours. Okay, team, we now have that bleed under control. I want 1 unit of red blood cells started now. I want them to go through. Now, with that pause point, a lot of that clinical resource management is about telling the team what to do, but not micromanaging them, okay? And so an example of poor micromanagement in that space is, okay, wet. I now want you to hang a packed red blood cell unit. I want you to put it on an infuser bag. I want that infuser bag inflated, and I want it to go through the right IV. No, that is not an effective way of communicating. Just say to the team, wet, I want you to start a unit of packed red blood cells now, please. And they should know that they need to infuse it through that IV. They know that they need to put a pressure bag on it. They know that they need to warm it. And that's good clinical resource management. The last thing I'll talk about on the slide is the debrief point at the end there. That's highlighted, boldened, and in red. Debriefing is a really important part of getting good learning experiences out of resuscitation medicine, be that in trauma or a medical presentation or a surgical presentation. But it's also about expressing and understanding the human factors of what can be done better within the team. And that's about effective communication, effective procedural changes, etc., etc. Okay, so let's start talking about some role allocation within the team. This isn't the world according to Nick. This is a combination of lessons learned, some unit experience, some deployment experiences for some people that have been fed back, but also from what doctrine, not only in the United Kingdom, but also Australia tells us is probably appropriate. It's also how many civilian trauma systems work in, say, New South Wales, the Northern Territory, and in Queensland. So, airway. Airway can be a medic, it can be a nurse, it can also be a doctor. It can be an anesthetic technician who's a dual trained medic and anesthetic technician, and it can be any iteration of experience from any of those levels, as long as they're sufficiently trained to deal with the airways that are within the unit's pack-up. Okay, so the airway person needs to be a master of airway basics, be that jaw thrust, head tilt, chin lift, the use of a nasopharyngeal airway, an oropharyngeal airway, an eye gel, all those things need to be the basics and understand how to use them and intervene appropriately as per what vital signs they see or patient signs, so those hard signs, those objective signs they see the patient feeding back to them. They need to understand adjunctive airway interventions, and that's a combination of, say, 2 NPAs plus a jaw thrust or a Goodell, etc., etc. They also need to understand advanced airway interventions, and this is about that difficult airway or that advanced airway skill for the obtunded patient. This is about understanding the airway vortex. If you're unsure of what that is, feel free to Google it. It's about how to crike a difficult or challenging patient, be that with an advanced anatomy, but also about who not to crike, be that really obtunded patient, and about what takes a priority with that patient. We need to resuscitate them first before we start putting them under or doing anything with the airway. So that means giving them blood, stopping the bleed mechanically, and then continuing down a pathway. The airway person needs to work in austerity and understand that the airway is not the sole priority. And I say that because in the past I have worked with some anaesthetists who are solely based on putting a tube down someone's throat. And they may be good at doing that, and I'm not bagging them for that, but they need to understand that resuscitating a patient first before sedating and paralyzing them is the most important part of that, especially in trauma medicine. As part of this scope, understanding how to ventilate, pressure your patient and oxygenate them is a masterful skill, and therefore they need to master that. So that's understanding how the technique of bagging is appropriate for your patient before you even put them on an actual ventilator. And that's about PEEP and a PEEP valve and where that goes on the bag and how the bag is squeezed and how many liters of oxygen you need to get effective oxygenation for this patient. But then also knowing and mastering ventilator statuses and what modes are best for your patient, etc., etc. Circulation or wet. The wet or the circulation person is a master of IV access, be that by eye or feel, but also by ultrasound if needs be. Ultrasound guided cannulation and venipuncture is a very bespoke skill, and it takes a lot of practice. So to say that you need to be a master of ultrasound guided cannulation I think is a bit far, but understanding how to approach and insert an IV, what you need to do that, and that difficult access patient and what they look like, that really obtunded patient who is got a is hemodynamically unstable, and understanding the mastery of IV access. The wet also needs to understand what medications are in their packup, the purpose of those medications, and the adverse effects of those medications, be them transaschemic acid, paralytics, sedation medications, analgesics, so controlled analgesics, what are contraindicated for a trauma patient, etc., etc. You need to understand how to set up and establish infusions and blood products. And this includes the last point, which is warming cares and fluid warmers, and where the fluid warmer belongs in the process of administration, transfusion, or infusion. They need to recognize what analgesia is appropriate and preempt what their team leader may ask for. And they need to understand what's preferred or what is protocoled, and that comes down to standard operating procedures and what they basically dictate the team should be giving that patient. But they also need to anticipate access complications, and this comes to the next point, which is IO access. So be that a 5-pin external IO or a easy IO to the head of humerus if, say, there is a traumatic amputation to bilateral lower limbs. In coordination with this, they also need to understand the dry person's role, their responsibilities, and they need to be interchangeable with that person, because if they're isolated to, say, the patient's right side, they need to know that they can do the dry procedures on their side of the bed so they don't have to run around airway or team lead. So Procedure, or the dry person. Dry person, their role and responsibility is to be able to decompress the chest. It's to be able to do a finger thoracotomy on a tensioning pneumothorax. It's the ability to insert chest drains, be that a Heimlich valve or an underwater seal drain. It's also about application of splinting, pelvic binding, manual traction or traction devices, be that the Kendrick's device or any of the other ones that we have in service. It's also about being able to utilize the point of care ultrasound devices that you may have to be able to get an early diagnostic picture of your patient. But it's also about being able to intervene or assess in the C of the March or the C of the CABC to assess not only the chest wall but also the abdomen, to be able to assess the limbs and know what patterns of injuries may bring particular complications. The scribe is normally the rigger to the resus, and they are responsible for being the quiet voice in the team leader's ear, or being the calming voice that asks for observations that may have been done, procedures, or what size IV's been inserted and what time it was done. They also timestamp and ensure that procedures are done to a particular rigor. As the British, we've identified already, the British are very, very, very good at this. And this comes normally from a very senior nurse, otherwise a very senior medic. They are responsible for identifying and then labeling your patient, and that's about either putting a band on, either on the ankle if it's there, or the wrist, or getting a unique identifier for that patient, and making sure that documentation, therefore, is labeled correctly and not mistaken with someone else. So they need to sanitize and isolate that patient's documentation and identity profile from any other patient. Therefore, they're a custodian, so that means any equipment, items of jewelry, or rings, etc., are then put with the scribe and they are bagged separately. But in saying that, they're the team leader's brain, and so if there's a clinical bias or a sole focus on, say, access, and it's slowing down the rigor of the resuscitation, it may distract from further injuries that are causing the patient to descend. And a good example of this is we can't get access in this bilateral traumatic amputation patient. We're focused solely on access, but in actual fact, the patient is desaturating and is hypotensive on the monitor. And the team leader may be so task focused on getting an IV, they've been distracted from the fact that they're not actively resuscitating their patient. So therefore, they need to be the team leader's brain and help them see the bigger picture. The scribe, if they're a senior more nurse, need to be a standby support to not only the airway but also the team leader. And that means that if the team leader is drawn into a procedure, be that something that hasn't gone quite right the first time, an airway intervention, for example, then if they get involved in that airway, then the scribe then reverts to team leading. The scribe also needs to be a master of all the basics that we've already talked about and we will talk about, and that's about basic IV interventions, airway interventions, about how to set up equipment, because if those other circulation or procedure people get caught up, then the scribe needs to be able to tap in and know the equipment that they're using, and that's about muscle memory of how we establish or set up a fluid warmer, or pressure a bag of fluids, and then it becomes second nature for that person so that they're not a liability when there's a high stress, high fatigue environment. The team leader is the rigger to the resus, and this comes back from the scribe. This then pushes on to the team leader as well. A really important part of this is that they are a hands-off leader. They're a hands-off leader. So that then means that if there is a difficulty or a challenge, they've equipped and forearmed their team to be able to do interventions without them needing to be there holding their hand. And that could be an advanced airway intervention, such as an endotracheal tube or a crike, and that airway master is able to do it independently and autonomously without the team leader talking them through it or breathing down their neck. And that comes down to professionalism for the TL. And this is about the whole concept and idea of our anaesthetists, our ED consultants or RMOs, our surgical colleagues, about them, if they're the team leader, they need to know that they can trust their team and take the hands off and just let their team take care of it. In saying that, they need to be cool, calm, and collected. But they need to have a glance and see situation awareness and see that from a bound backwards. They use a shared mental model approach, and this is about basically, team, we have a hypovolemic, hemodynamically unstable patient. I'm happy with the A, the B, the C, the D, and the E. However, I now want 2 units of warmed blood put through the IO on each head of humerus right now. And then, wet, can you tell me when you've completed that task? We're not moving any further through the resuscitation process until we see an improvement of heart rate and blood pressure. Any questions for me, team? No? Do that now. And so that shared mental model sets a gradient for the team and helps them understand exactly what the problem is. In saying what I've already said, there is a need for the team leader to be a standby and a support to any of the procedures that are conducted. And they too are the master of basics, but also advanced interventions. And this is really important. So to wrap it up, takeaways from this. We need to train how this works and what we do with our team resuscitation processes, especially in the role 1. This comes down to rehearsing our procedures and our patient presentations, and knowing what our preferred medications, our preferred fluids, and our techniques are. And so this is about, we put 1 unit of packed red blood cells into our patient. Simultaneously after this is done, I want TXA given on a separate line. Our preferred medication will be ketamine, and if we have a labile blood pressure in a hemodynamically unstable patient, we will not give midaz. And so these are examples of some of the medications, fluids, and techniques. This is also about how we approach finger thoracotomies and where that sits in the resuscitative process. As much as anything, this is about practicing these techniques and making sure that we consolidate the knowledge within our teams and units and make sure that everyone within our units understands exactly what medications we use, they understand weight-based dosing, they understand bolusing of that medication and then ongoing infusions, etc., etc. And it's not just isolated to pharmacological interventions, it's about how we wrap and warm our patient, how we apply tourniquets, how we recheck our tourniquets, etc., etc. I think one of the biggest things is that we don't let skill fade occur, and we champion subject matter expertise around this entirety of role 1 team resuscitation, because if we lose it and it's siloed only to 1 or 2 individuals, the collective knowledge will then fade into non-existence. That's all from me. Please feel free to reach out to me on social media or in the comment section on this video. I'm happy to engage in further discussion. Thanks heaps for coming. Bye now.